The other thing that's really important for physios to understand is, I always say to the patients, is this your first ever knee injury, or have you had a knee sprain in the past? Do you know, because sometimes we've had people that have had what is actually an instability episode, not an index knee ligament injury.
Sure, okay.
So, and then of course, you're wasting 12 weeks of their life in a brace.
Sure.
Because it's not going to heal, because the injury happened years ago.
I think it'd be really cool just to give maybe the new physios who maybe don't know who you are, quick 5-minute rundown, when you started physio, where you are now, and I guess how you got to this ACL unique load. Like, where did your pathways lead you?
How I got here.
How you got here.
Yeah, it's interesting because my career, like, I feel very lucky. And because I still love what I do. So after all these years, I'm still passionate about what I do. So I started off as a new grad. I did my undergrad in Adelaide, and then I started off as a new grad at the Royal Adelaide Hospital. So I did back then that was the sort of very common pathway. So I did just a general rotation. And then I went to the UK and I worked there for 6 years. And I worked in the NHS in a number of different, mostly in the hospitals. And then I did some sports clinic work at night and some sports work on the weekends.
So back then you could do both.
Yeah.
I feel like at the moment you can't, it'd be weird.
Yeah, although because the NHS was sort of like 8 till 4, it was very easy to have another job afterwards. In fact, it was almost necessary living in London with an Australian dollar at that.
At that level, That
was the only way I could afford to live well over there. So I got a really good medical grounding through all my hospital work, and I did a lot of orthopaedic stuff then, acute orthopaedics as well. And so I suppose then I came back and I did my, back then it was called the grad dip in manipulative physiotherapy. So I sort of did the spinal, like the MUSC pathway back then. And then I moved to Melbourne soon after that. And then I was just fortuitous in that there was a great physio called Mary Toomey, who I'm sure you might have heard of.
I actually haven't, no.
She used to do a lot of work in footy, but then also
AFL.
in AFL, but then swapped over to rugby, to the Storm. And she was leaving and she had a knee list. So she said to me, Jane, do you want to take on my knee list? And I was very fortunate because there was a lovely surgeon that she worked closely with called Mr. Ian McLean. And he was, I used to go into surgery with him every Friday. And the team he used to allow me to examine everyone under anaesthetic and mentored me about how to do a good Lockman's and a pivot shift and all of these tests. So I suppose I had a very patient and kind mentor, and then we had a very cohesive team with the surgeon and the sports physician who used to assist at surgery, who I also worked with, and then me. And then I would just be observing all sorts of different surgeries, and then we would also have a catch up about, where the patients were at and what their rehab was doing, and so it was a very nice communication, and it really worked very well. So I suppose that's where my interest in ACL sort of started.
So when you took on the knee list, was it something that you were like, I love, most physios love knees, right? Who doesn't love a knee? But was it something that you were like, oh, this is my dream? Or was it like, oh, this will be cool?
Not really my dream at the time, but I suppose because I was then also working with Lynn Watson, so I was doing some shoulder stuff, and also I was quite interested in the MUSC stuff still. So I wasn't really very super specialised at that time. But then I suppose as I did more and more work in that area, I became more and more interested. And then in 2016, so that was like 10 years later, maybe.
So you did that for 10 years?
Oh no, hang on. 1998 I moved to Melbourne, so it's quite a bit longer. I did then my level 3 sports and, got my sports title as well.
So you did a master's or did you do it from the experience?
No, it was grandfathered at that time.
Because when I did a little dig, I was like, I don't think she's got a sport master's.
No, that's right. So back then, so everything was very different back then. So then I did a level 1, level 2, level 3 sports, and then you could sit an exam. So and then I got invited to sit the specialisation exam, because when specialisation started, it was really, there was no training program like there is now. So they just invited a number of people
tap on the shoulder
to say, you know, would you like to sit this exam? You have to sit it by this date.
So you couldn't apply? It was something that they, like if you're out there and you've networked, they go, look, you're ready?
You still had to apply, and you had to suit a number of criteria, from sporting experience to research experience to academic sort of qualifications and things like that. But I suppose it's different now because the academic qualifications have also changed.
So what made you want to do specialise?
Specialisation, yeah, it's a good question. I'm not really sure. I think every time I've done more academic study, I've enjoyed my job more.
Sure.
And so I suppose I just got to the point where and also you could nominate a subspecialty back then. So I did nominate knee as a subspecialty. Sure. So, and I set my specialisation in 2009. I actually did that. So, and I suppose that really, like, I did it I self-studied over 2 years, and I had very young children at the time, like 0 and 16 months old. So it was a brutal time of no sleep for a couple of years. But I did a lot of reading, and I was just very interested about, you know, and I learnt a lot more over that time. And then in 2016, I was awarded a Churchill Fellowship to look at ACL injury management algorithms around the world, look at rehab programs, prehab programs, non-operative programs, and that was amazing. And I suppose that was I was awarded that because it was, it's very competitive to get it, and you have to prove that there's a problem in a Commonwealth country that affects a common man in the Commonwealth country, but also that you have a plan of doing something about it when you come back. Okay, and you have to, it all has to be pretty set out before you apply. And so I suppose at that stage I certainly knew we had very high operative rates compared to the...
It's like 85%, I remember.
Yeah, 85 to 90%, and you know, like at
highest
that time, you know, the Frabel study had been published with, you know, 50%, and so I knew we had very high operative rates compared to other places in the world. And so I wanted to understand more about why that was, too. And so...
this was 2016, 2018?
2016 I got awarded the fellowship. I studied in 2018, which was probably lucky that I got in there just before COVID. And so I went for 3 months, and I went to... started in the UK, then I went to the Netherlands, and then I went to Sweden, Denmark, Norway. Then I flew over to Ireland. Then I went to the US, and I visited a number of different amazing clinics that were implementing really, you know, good evidence-based rehab as much as there is. But also I went to the Frabel study, you know, side. I went to the Compare trial site in Rotterdam as well, and then I went to visit Enda King in Ireland, and a few other really amazing clinicians as well, and then Chris Powers in the States as well.
Amazing.
So it was really amazing, and just to spend time with all of these people, it was a real indulgence, do you know, like academic indulgence, just to...
And that's over a 3-month period, so you're just going from here to here to here, just ticking, amazing.
And the Churchill Trust was amazing because they funded, you know, nearly all of that, obviously. And they were also very flexible, you know, because I remember, like, I was in Sweden and this guy said to me, "Are you going to visit Enda King at Sports Surgery Clinic? You have to go there." And I'm like, "Well, but I've only got 2 nights." And he goes, "You just got to make it happen.
Get there. Get there. What are you doing?"
I rang them up and I was like, "I know it's St. Patrick's Day, but can you get me there?"
Was it actually? Oh my God.
So I did end up going there, and that was great. And I've since gone to visit Enda at Aspetar as well. So, and I love what they do. It's like the Disneyland.
Absolutely.
The Disneyland of
looking
ACL
from it now,
that's
a great way to compare it, actually. It is a bit of a theme park in some senses, and what they're producing and where it is now.
And it's great for the rest of us. I mean, some of it is hard to implement in a clinical, in all clinical realms, just because, you know, it's very expensive to set up that sort of level of equipment and space and all of those things. But you can still take, and I suppose that's what I've been passionate about, is try to take what the research is telling us and how to translate that as best as possible into the clinical realm. And so I suppose after I came back, then I started purchasing some equipment because I was thinking I really need to be able to do better strength testing analysis, and I wanted to do proper. I was already doing the best evidence, that I could afford
with the equipment
that I had of a return to sport test. But I certainly then sort of upgraded some of that as well, which was helped by buying into a clinic and then having a little bit more control of the spend, I suppose.
So you bought into that clinic when you came back?
Yeah.
Like, were you working there before you went?
Before I went, actually.
Yeah, cool.
So that was the Churchill, and then I suppose since then, because that's a long time ago now, 2009, that I got my.
Did you have to? What did you have to do when you came back? Did you have to produce like a report and a document, or work on the other side?
So
I assume they wanted something tangible out of it.
You do. You have to produce a report, and then you have to give a little talk at the Churchill medallion thing. Well, from memory, I can't remember, but I think it was like 5 or 10 minutes. Like, it's a short snap.
Yeah, like a pitch sort of thing.
It's a pitch.
Yeah.
In fact, that's the whole Churchill. Application is quite interesting because there's a number of different pitches that you have to prepare, from the 15-minute pitch to the elevator pitch to the, so there's a number. That was really good training to just do all those different pitches at that time as well. And then at the end, and then, I then had many different pitches, a 20-minute, a 10-minute, a 1-minute, summary, so that we had to deliver it formally and also produce a report, which you can access for free actually through the Churchill website.
Oh, amazing, cool.
Which has got, it's not research, but it's a clinical sort of summary of what my travels.
Some people might find it more valuable than research.
In fact, the introduction is probably still, and in fact, because I just recently got some post-impact funding from the Churchill Trust to develop this new website that I'm working on called The Good Knee, and so they've been really generous in supporting that development as well. But then I look back on all my conclusions and recommendations, and I was like, wow, I'm actually doing this. Working on a shared decision-making tool, to aid, because I thought, well, there's we do have too much surgery here, and it's not, based in the evidence. But I really believe that the way that we can change that is to give people more knowledge so that they can make a better informed choice for themselves based on good information from the research.
So how would
rather than trying to change surgical behaviour or surgical, so
not change not change an industry, change the patient.
Change the patients, because that's the bigger group, and they're the ones that actually in Australia, people are wanting a lot more information, and I suppose
they can just claude it right now, right? And you have to be at the point where if you don't know more than AI does, why
you're in trouble as a practitioner.
Huge in trouble,
And in fact, that's what I often will say to the younger practitioners. You need to make sure that, like say in ACL injury management, there's only 3 big pivotal RCTs that you really need to know, like the Canoon trial, the Compare trial, and the SNAP trial, that are reflective of different cohorts. And you should know them if you're going to do this, because really that's the underpinning of the good research that's been done that shows, about 50% of people can do okay with non-operative management. In fact, very similar to ACLR outcomes. Without having surgery. So surgery isn't necessary for everyone, but it is necessary for about 50% of people, according to the best research we have. And then, of course, it's trying to help the patients through the journey of how do they decide for them, should they do the operative pathway or the non-operative pathway.
So how do you see that tool, I guess when you say those toolkits, how do you visualise that? Is that something that like every person, let's say it's a shared role and you've got a sport physician, a physio, a EP, a doctor, and you've got all these in there. Is there key points for each line that they should be checking? How do you see that being frameworked for everyone involved?
I'm going to talk about it in a slightly different way. So when I came back from my Churchill Fellowship, in 2018. Well, then COVID came not so long after. And in fact, I met Tom Cross, and that will be another story. We'll talk about the cross-bracing protocol while I was delivering some of my Churchill findings at the Australasian Sports Physicians Conference in Canberra, actually. Here we are again. It's a common theme.
The Mecca.
Anyway, then Steph Philbay was coming back to Australia because she was based over in the UK for a while. And I said to her, I really want to do some research into shared decision making because I think that could be a way forward in trying to change operative rates. And so she said, and it worked well because it was research we could do over COVID, that we did surveyed nearly 800 patients and about 300 or 250 physios, thereabouts, into what they knew for the physios, what they knew and what they told patients, and from the patient's perspective, what they were told by who. Do you know, and so basically then we did those two projects, and then we interviewed 10 of each group in a semi-structured interview. And interestingly, what we found out, say, from the patients, that 85% to 90% of them were told, by surgeons that they needed to have surgery, and it was the best. It was the best option for them if they wanted to return to sport. And interestingly, it was 60% from the physios, so it was still quite high from physios. And rarely were they told by either physios or surgeons that the outcomes are similar on average, like rehab and a delayed reconstruction versus early reconstruction. So even though physios said when we did that survey that they knew, they said that the outcomes were similar, it wasn't what they were telling patients. So there was a mismatch in what physios said they knew and then what they were telling their patients, and then therefore probably patients were making choices about their health journey and management based on inaccurate information. And so then after that we set about making a free online patient decision aid, which you can access, www.aclinjurytreatment.com, and it walks people through, I've injured my ACL, what does this mean? What are the consequences? What are the management options? How does the research compare?
Huge.
And so then it doesn't actually spit out like Claude or any of those AI tools like you should have a reconstruction, or it doesn't actually tell them that. But what I think is really powerful is that, say, I see a lot of acute in the ACL seasons, which are like, the European Japanese ski season and after that, and then also coming up, unfortunately, soon with all the winter sports and skiing. And so I have acute, injury spots on my list every week for acute knee injuries. And then if they've got a confirmed ACL, we send them the link to the patient decision aid before they come in, so that then they can review it before they come in, and then it makes the conversation much better. And they ask more informed questions, and it can be you're not starting
ahead, right?
You're not starting from absolute scratch, or worse, from misinformation that they
you're
might
not unwinding something to then rewind a different way.
Exactly, that they might have found some misinformation online somewhere, which is it's a common problem, isn't it?
Or even just the fact that they've had a bunch of friends that have done an ACL and they say you've got to see this person. And like I feel like that relate, like the knowledge transfer of humans is just such I find it so much more powerful in physio than anywhere else in my life, where we believe, like as a survival instinct, that one person can be just as powerful as 100 studies.
I know, and that's certainly
insane.
That's the other thing that I think I'm interested in, and I need to do more reading about that, is understanding, because as you say, you could give them this beautiful patient decision aid with all this information, research-based, the pros and cons of each option, and then their uncle had a really bad experience with something, and then they'll go, But no, I'm not going to choose that because that happened to my uncle. And I'm like, but hang on.
But what about literally this mountain pile of people where it didn't happen to?
In the bracing protocol, again, I like to give people all the options. These are the different braces. These are the costs. This is the pros and the cons, in your situation, because you're going to be on crutches for this many weeks. And then they turn around and go, I'll have this one. And I'll say, oh, okay, why do you choose that one? Oh, because it's pink. Okay, right, okay.
Sure, man, sure.
So people make decisions based on things that maybe we would think that they shouldn't, but anyway, that's their decision.
And I think that's just part of our challenges, right, as well. That's why it's kind of fun. Well, not fun, but it's part of it because you are walking those lines and hearing something like that could just be like oh, sure, have the pink one. I didn't realise that was an option. We need now a bunch of pink ones. Can we colour code these? Make our own custom ones
but
now.
maybe that's a thing too, because, if you're thinking, unfortunately, the ACL injury rates are really exponentially increasing for all of these countries that are tracking it, and most in the 5 to 14-year-old age bracket, which is really terrifying when you think 10 years post, 50% of them are probably going to have OA. And this is in males and females as well, is that maybe we need to be, if they're doing bracing, maybe we need to be making it more appealing, you can have this, but you can have it spray painted pink, or
it's the same with your cast, right? When you went to hospital, they were like, what colour do you want? And I'm like, oh, red. 100%.
Yeah, because it's cool then or something.
Because it used to be white, now you can get them colour and they're waterproof. I mean, there's obviously a marketing side for all of that, but when it becomes more of a mainstream thing...
But then it's sort of compliance as well, isn't it? So that's the other fact. But so then going back to the journey, I suppose then that's sort of the decision-making journey part of it. And then, of course, from there... when I was delivering this talk in Canberra, then I met Tom, and he was delivering his information about the cross-bracing, but he'd only done a few patients.
This is so you've done the fellowship and it's pre-cross-bracing?
Yeah, so no, it was just about the very beginning. Yeah. So Tom had done the first bracing patient, I'm going to say in 2014 or something. It was quite a long time ago, but he hadn't done many. And then when I met him in 2020, which was just before COVID, and we did this talk in the same session, and I was talking about shared decision making, and he was talking about the cross bracing protocol. And I said to him, we should collaborate because we're, we're talking in the same,
we are the same.
We're in the same page,
for sure.
So, and also this is really important for the cross bracing to do shared decision making. So the pros and cons of, early operative versus, rehab and delayed operative if required versus, bracing. Because of course, ACL management in the past has really always been on the understanding that the ACL doesn't have a capacity to heal, right? And it sort of was a replacement of the ACL.
Well,
using
I remember
tissue, right?
And sorry for a side tangent, but I remember it would have been 2021, and we already knew this, right? But I remember a patient, a colleague of mine had a patient where they literally got a piece of paper from the hospital that flat out says the ACL cannot heal.
Yeah.
And I'm like, this is a substantially incorrect fact given from a hospital to a patient. Insane.
And in fact, even now, there's some AI platforms that still tell you that.
Interesting.
So it's interesting because I've got some screenshots from Google before the Canoon healing paper was published, and it said the ACL cannot heal, it doesn't have a blood supply, therefore that's why you need to have surgery, etc. And then after Steph Filbay published that report on looking at healing in the Canoon trial subgroup, particularly the delayed, obviously the rehab plus optional delayed if required, because of course then they had a group of non-operative managed people. That they could have a look at their ACLs, and they had the MRIs to do that. Then once that was published, it was only a matter of a month or so that Google actually changed their actually advice. When you Googled
it changed.
And it said the ACL does have a capacity to heal according to current, recent research, and this may be interesting, in the future or something like that. Whereas there are still some AI platforms that I've searched, because I search every now and then just to see what patients are finding. And they still tell you, and it's only if you go deep into them and keep prompting them to go,
where is it
come on, what about this and this? Oh, well, you know, but the first thing is that the ACL doesn't heal.
Can you search like where those sources are coming from? Like, because surely sometimes it pops up and goes, this is
where they're getting it from.
I reckon that there's a collegiate of someone who wants ACL surgeries to continue, and they're pumping dollars into an SEO somewhere that's writing these things up.
Maybe.
Man, that'd be extremely easy to do.
Yeah. So, because it's only if you go deep into it that you find it now. So that's part of my motivation to do the good knee. So maybe some of that and pay for some SEO. So that
optimization.
It basically feeds some good information as well, and also that patients then can go to a credible source, directed to a credible source, so that they can, and it will have links to all the good published research, because you know, patients are very informed these days, very informed. And in Australia, because I teach around the world, obviously I see lots of different health systems, and I suppose that was the other really interesting thing when I did my Churchill Fellowship, is that in the countries such as the Netherlands and Sweden, which are predominantly public health systems, they had different algorithms of management, so that, you know, basically if you're in the Netherlands, you'd ride your bike for 3 months, and then if you weren't happy with your knee, then you got your orthopaedic appointment and your MRI, right?
You ride, because I mean, they ride everywhere anyway,
they say,
live your life.
Do some rehab, but ride your bike, whatever. And then...
you don't have to get an exercise bike in the Netherlands.
In Sweden, again, you sort of do non-operative management, and then if you're not satisfied with your knee, then you get an orthopaedic appointment. This was back then. They might well have changed the algorithm by now, but I don't think so. So
and that comes from a doctor. That comes from like the first person they see.
Yeah, so like from the hospital, wherever they go. And so...
there's a collective agreement that's the flow.
Yes, and then I suppose... like I often say to patients, it's a bit like when you sprain your ankle. You know, it's sort of walk on, it's swollen, it feels sort of weird, and it's, you know, painful. But you know, 6 weeks later, it's very different usually. Do you know, like the swelling's gone down, you can walk on it.
It will change
sometimes
how you
forget,
feel.
You forget which ankle it was by then. Do you know? And that also happens with knee injuries to a point. Do you know, like, and you don't think immediately when you sprain your ankle, oh, I'm going to have an ankle reconstruction. I've just sprained my ankle. But it is something that people think about ACL injuries. But I mean, there is a higher risk of instability, obviously, with a knee injury, like an ACL injury, compared to probably an ankle injury. But it's still, So it is interesting to see that in different countries there are different rates of operative management, and it is somewhat based around their algorithm and their funding of care. Whereas in Australia we have a very mixed triage of ACL and acute injuries. From you could go to the public hospital or the private hospital, you could go to the GP, you could go to a physio. Do you know, like, and it sort of depends on who you see first.
I mean, the journey you'll go.
Most people will go to see the GP because they want the Medicare bulk billed MRI.
Or the mum will take the child there because they don't know where else to go. Or that's just the way they do it.
But you're going to have because you're going to get a bulk billed MRI, and you need a GP referral for that. Physios and
shout out refer.
Yeah, and. So then, and then from there, you know what the injury is. And then I suppose from there, that's then when you decide where to go next. Do you know? So, and many GPs will refer straight to an orthopaedic surgeon. But then that's also got a wait list, usually for 6 weeks or so. So in the meantime, they might come to a physio, or some people might go.
Honestly, a 6-week wait list would change. From my experience, in Canberra, 2 weeks. Literally, they'll just get them in.
I suppose it just depends, doesn't it, on where you are and what the access is. And, you know, like teaching around Australia a lot, there's some challenges in different parts of Australia, even to get a GP. Like I was in Merimbula teaching about 6 weeks ago, and they were saying to me there, it's a 3-month wait for a GP appointment, which is where like some of those...
refer would do well.
Exactly, because really you just need a referral for imaging. Do you know, like...
100%. You don't need to actually see the GP, you just need the system.
Or you could be done by telehealth, But anyway, so that was now I'm trying to think where we were on the journey. So, when I met Tom Cross.
Coming
back to the journey.
Yep.
And then, then I met Tom, and then I think, then I came back to Melbourne, and we started, I think that's when COVID started, and we went into lockdown, and it was interesting because we had all these people that are coming back from skiing, which brought us a bit of COVID as well into Melbourne, I believe. But because surgery was then not allowed, do you know, like because they stopped doing surgery because it wasn't
essential, right?
Exactly, it wasn't. You know, there was different rules through different lockdowns. But because of that, then there was a few people that chose what they said, well, I'm waiting anyway, I can't have this surgery, so I might as well try the bracing, you know. So I think one of my patients was brace number 4 in the cohort. And so that's when I started doing more cross-bracing then. And I suppose now I'm probably up to about 250 myself, do you know, from Melbourne. And obviously Tom Cross and I work very closely together still, in that he'll, you know, do the MRI classification and telehealth the patient. And then I look after them and brace them and rehab them, and then that from there. So, and then I suppose from there, you know, the first 80 in the case series was published, and from there, then we've now started an RCT, which we're wanting 180 patients. So if anyone, it's called the Embrace trial, and it's run through Melbourne University. So if anyone knows anyone with an acute knee injury.
So they've got to be, what are the criteria?
The criteria is they have to be between 16 and 40. 16 or 18? Check that, but it's definitely 18 to 40, but it might be 16.
Sure.
They have to be within 16 days, ideally, of injury. So, and then I think sometimes we've pushed that out a little bit. There's some strict criteria, but I could have been pushed out to 20 now. And then there's also they're the main criteria. So the time and also the age group. And then, of course, they have to be willing to be randomised. So because they're randomised to either early surgery or bracing, with the option of surgery later if required. And then for the patient, the advantage is that certainly if they're in Melbourne, and I think there's some, we're getting some established in Sydney too, if you don't have private health insurance, you can get it done through the public system. But certainly that's more accessible right now in Melbourne. But the trial is also running, it's a multi-centre trial. So in Brisbane, in Perth, Melbourne and Sydney. And if you've got private, we pay the study pays the gap fee. And then you get all your rehab paid for. And if you're in the bracing group, you obviously get your brace provided and you get all the rehab as well.
Pretty good deal.
And it is pretty good. And it's, you know, good evidence-based rehab, you know, according to what the best literature is at the minute. So basically that's the Embrace trial. And then if you, that's what I was going to say, if you're a physio that is interested in providing for it, if you have a patient that you then refer, if you think they're appropriate and they're happy to be, they're sort of a bit ambivalent about their treatment pathway, then
I actually know the personality. I can almost feel the person that would be like keen on this.
It is a different person than the people that say, I want to come in and do cross bracing because I don't like surgery. I'm an anti-surgery.
Can it also can it be first, second, third?
Oh, sorry. Yes, it has to be a first time. It has to be first time, and not a ACLR that's ruptured. It has to be a first time.
Multi-ligament or just
not a
isolated?
multi-lig. But we'll sort that all out with the MRI. So as I was going to say, with the physios, if you're a physio and you send somebody in, you can then do the training to then provide that patient with their ongoing care.
Awesome.
Like we have bracing clinics in each centre just because logistically we can't have braces everywhere.
Yep.
So there's a central bracing clinic in each city, but then the physios can do the training and then we can support them if they need.
So they don't. The physio doesn't need to be in those hubs. The patient just needs to go get braced and then come back.
We do have physios in all of those hubs that have done the Embrace training.
Yep.
But of course, we are now happy that if people refer in, that they can then do the training, because then it's a little bit of a bonus for the people referring in, that they don't lose their patient.
Oh, absolutely. Yeah. So is there something specific about the embracing training that, if I was a skeptic, I would listen to this and be like, I can brace a knee at 90, why do I need the embrace or the training for that?
Well, I suppose it goes through, all the training from brace fitting, because if you are managing somebody, whilst the brace fitting clinic, so obviously I'm one of the brace fitters and our clinic is one of the brace fitting clinics, we have all the different sizes because, the brace that we're using, the Bauerfeind Secutech, has got 7 sizes and a right and a left. So can you imagine you've got to have like 14 braces just to be able to brace one person that walks in the door.
Yeah.
And there's some tricks about fitting that brace well. It used to take me 45 minutes. Now I can probably do one in 15 or 20 minutes. But it's a process. It's a bit of a process. And there's lots of little hacks and things.
And if it's Bauerfeind, it's an expensive brace. So it's win for the patient.
It's an expensive brace. It's about $1,000 worth for them.
And I assume it's comfy too. Right,
well,
compared
as comfortable as a knee at 90 degrees can be, probably for 4 weeks, but it is more comfortable than the ROMs that fall down generally. But even as a trial physio, you will have to change the brace. So we fit the brace initially at the bracing centre, but then you would have to change the brace as, after the 4 weeks, then it changes weekly. So you have to know how to do all the block changes. And then as the person atrophies, often you do get some muscle wasting, then you need to know how to refit the brace to them, or if they're getting any skin irritation. There's lots of little things about braces in the training. Then there's specific rehab part of the bracing protocol, so that we can try to limit the wasting and atrophy of the affected leg. But also, as the brace changes, that you try to match the range of motion to the new bracing range of motion, which prevents stiffness later on, but also try to improve and progress their weight bearing, so they don't get things like bony stress when they're reloading. But also work the muscles in the new range so that they get less, muscle atrophy. So there's quite specific rehab processes through the whole bracing protocol, and then things like I've designed the rehab protocol for both groups actually in the Embrace trial, and I did a really thorough. So it is a little bit evolved from the original bracing protocol rehab, because I did a very thorough look at all the literature and look at all the different exercises and different ACL loads. So things like open chain leg extension, we don't add in till 16 weeks. I mean, we don't know exactly when we should, but it is something that does stress the ACL, and we know that the healing ACL looks it's less dark, it's less mature to collagen. So
you're picking your time for transduction of the ACL in terms of those stresses. You're picking a particular window. And that's a clinically
it's a best
estimate of when it should be.
A best guesstimate, if you know what I mean. But because actually, interestingly, in all those papers, what they say is say 90 to 60 degrees, 90 flexion to 60 degrees. When the quads work, it actually pulls the tibia backwards, and it's only when it gets 60 to 0 that it starts to pull the tibia forward. So you would say that this is protected ACL healing, because we obviously put the knee at 90 degrees to approximate the ruptured ends of the ACL and hold it there. So you hold it still a bit like akin to if you break a bone, say. And then as the brace moves out, it's still protected in that range, even if you're working your quads. But then as it comes into this range, this is where you would start to get some of your stress remodeling of the ACL.
Because you don't, again, if you've just gotten to that point, because it's a long process, when you just get there, you wouldn't obviously load it straight away.
No.
Because it's a new range and you do have if you were talking about stages of, if we just think about the ACL, then you would have stages of, hey, you've got the range back, then you can start loading that range at a certain point. That kind of makes sense. Yeah. That's why, well, I mean, even just theoretically, 16 weeks makes sense from that point of view, regardless of the
I mean, we know
factors.
that open chain exercises it's beneficial for quads return, and you know, in the ACLR group, it's safe from 4 weeks onwards, according to the literature. I rarely do it from 4 weeks because half the time they've only just got control of their quads lag.
You know,
so
patellofemoral's not
so
going to be
you're certainly not
happy.
going to be giving them open chain quads if they've still got a quads lag, and you know,
all those things.
All of those things, because you know what research says and how the clinical reality of stuff is something different sometimes.
So how many patients have you got now? You need 180. Where are you at?
I think we're at about 30 or so now. Cool. So we're chugging along, but we certainly need
charge it up a bit.
We need to,
I think it's great. I think that having some aspects where everybody wins in this situation will help. And I think that having I can just see from also the business sense of a clinic, then having someone go through that training when this is a mainstream thing now. Like patients know about it. I've experienced patients in sport where they go, hey, they've done it, and they come to me within 2 days and they're like, should I do cross bracing? And I'm like, okay, like there's now more training in cross bracing. It's now not necessarily something. So I can see even from a business point of view where you're trying to provide them, you know, the highest level of care, having a free training aspect to it is great. And then you're learning, patients learning, everyone's learning through that process.
But there is a very strict inclusion and exclusion criteria, and that's certainly something that when I teach the cross bracing workshop to physios and present on it, it's something that I'm very passionate about people understanding, because of course with any intervention it's only good if it's appropriate for that person. Do you know, like, so acuity is one of the things, you know, ideally within 16 days clinically, we like to put them in the brace because the healing rates do drop off after that, when we've looked at the stats on the bigger cohort that we have now. Also,
so that's changed, because I remember the original cross bracing paper was like a 10-day.
Well, actually in the first 80 there were people up to 28 days that were included, but we looking at the stats, day 16, you know, the healing rate does drop off. I think the other thing
typical for all ligament injuries, though. Your 2 week gap. If you don't get in 2 weeks, it's not going to heal very well.
I think the other thing that's really important for physios to understand is, I always say to the patients, is this your first ever knee injury, or have you had a knee sprain in the past? Do you know, because sometimes we've had people that have had what is actually an instability episode, not an index knee ligament injury. So, and then of course you're wasting 12 weeks of their life in a brace because it's not going to heal because the injury happened years ago. Do you know, maybe, or, you know, one of those injuries that they go into hospital and they say, oh, I didn't have any scanning. They said it was just a sprain, just to take it easy until the swelling goes down. So you're talking about like
it's torn in not in that 2 weeks, and they've had another injury, and then you picked it up.
3 months ago or something, and then when you ask them, they say, oh, actually, you know, 3 months ago I did have this thing where my knee gave way a little bit, and I went to the hospital and it swelled up, and I didn't have any scans, but they said it's just, you know, it's probably going to be settled down and it's going to be fine. But that was probably the original injury, and then the injury that they've now presented with is an index, not the index injury.
And it's quite hard on MRI, I guess, to then show what's in that time frame, what's acute and what's not.
I think specialist musculoskeletal MRI, you know, radiologists can actually identify this, because you look at the bone bruising patterns, you look at like if there's any involution where the ends of the ACL have sort of healed over separately and they're not like fresh, you know, so I think there are things that they look for. So it's, you know, first time injury, it's within 16 days ideally. No big sort of multi-leg or meniscal or bucket handle or anything like that sort of tears. They also have to be able to tolerate weight bearing, you know, with crutches or some sort of device with their knee at 90 degrees. And some people have chosen not to do the cross bracing because they live up 10 flights of stairs with no lift, or it's their right leg and they can't not drive for that period of time. There's many other individual considerations, as well as some of the medical considerations in that people have to take anticoagulants. So if they can't tolerate anticoagulation, or if they've had an increased risk of coagulation, like a DVT or a lung clot in the past, then they would also be precluded from going in the bracing protocol. So there's a medical screening, and then there's also a screening, an MRI screening, which is done by Tom or a radiologist to say this is the gap distance, this is the displacement of the fibres, this is the femoral footprint avulsion. And so we sort of look at all of those things to sort of give them a predicted healing rate. And so, and then there's the individual factors that the physios can ascertain. Can they handle crutches? Can they, those sorts of things. And then I suppose it's really up to the patient to make a decision like, okay, well, as my 18-year-old self who, played a lot of netball and touch footy, all sorts of pivoting things, if I was given a 50% chance of a good quality heel, then I'd go, okay, maybe not. Do you know? But as myself right now, I'd go, 50% is pretty good. Like that would suit me. Do you know, like, so
Absolutely.
It depends on your age and stage and pivoting demand, probably. But the RCT will tell us more because when we look at the functional outcomes of the case series, the 80 that we published, the ACLOS of 2 heels, which are the thinner or looser, longer ones, rather than the ones which are look like a normal ACL with a bit more signal in it. They seem to be at least equivalent to an ACLR in its functional. Return to sport. So
this was one of the things that I always thought about, because they're like, oh, it doesn't heal as well, or you do get some elongation, these kinds of things. I'm like, in the back of my head, I'm like, fair enough, but functionally we know the translation's different. We also know that if your body's ligaments are talking to each other, like the sensory perception and what you're experiencing is still very valuable information, even if it has that extra link.
I know, and that's the thing that is also, that coming back to one of my Churchill visits, I visited this centre in Cincinnati where Dustin Grooms does quite a lot of his research. And I would be fascinated to tee up with them with some of the cross-bracing things. So he's the researcher that looked at the brain activity when you rupture your ACL, and that your visual centres work much harder because the area of the brain that normally receives the input from the ACL is not receiving that input. So you have to try to tell your brain where your knee is in space by what you're looking, use your eyes more, right? So I suppose the thing is, what we don't know is, say if you heal your own ACL, does that change that? Does that,
compared to an ACLR or compared to none.
Do and then that because the neuromuscular control is really important as far as the re-injury risk, etc. And then the other thing that's interesting is that recently, and we've only had one of these at the moment that I know of, is that I had a patient who had an ACLOS of 2 heel, but it was continuous. It was a little bit longer and a little bit looser, and it had a little bit more glide in the Lockmans. And the surgeon decided to augment her heel rather than cut it and do a full reconstruction.
I've heard of this.
So because she said she would think that heel construct would have some important proprioceptive fibres in it. So we don't know enough about all of this yet, but I suppose there's lots of exciting opportunities. Do you know, as far as...
I think that's such an interesting way, because if you're going to do it, does internally bracing the ACL to heal, right? That's such an interesting thought. And this is coming full circle back to our chat with the patients. I got told that from a patient. That there was people, or they were interested, somewhere overseas, there was vague details from the patient that they were looking at actually doing surgeries where they actually stitch the ACL back together.
So there is, so went to Barcelona last December. Very cold.
Yep. What a stitch up. You assume Barcelona's warm.
No, not in the winter. Not in the winter. Anyway.
Is it Canberra cold or is it colder?
No, it was colder.
Oh.
But there's a really interesting facility there called the Cugat Institute. And Ramon Cugat, who's an orthopaedic surgeon, he's very progressive, and he's been doing some cross-bracing with young soccer athletes, the ones that have the criteria, the MRI criteria that suit the cross-bracing protocol, inclusion criteria. But for those who have displacement of their ACL, he's actually been doing a repair and then doing cross-bracing. So they're collecting that data. Yeah. And so I suppose we have to wait till there's enough data to know how that goes.
What's your take on it?
But it's an interesting... Well, I think that I saw a couple of them when I was over there, and they tended to get stiffer than the non-operative ones, because I think, of course, they've had a surgery, so they've had a scope, and then they've had something, attaching sort of into their bone, especially the ones with open growth plates. Do you know, like, that this is a thing that they tend to use with the open growth plates, which we can talk a little bit more about in a minute. So, of course, because you've had the surgery and the post-trauma from the surgery and you've got the swelling and things from that, then I think then when you put them into a brace, then they do tend to get a bit stiffer, just from what I could see, not from any research. But I do think, coming back to my 18-year-old self and then me now, the other thing would be my 12-year-old self or 10-year-old self. And of course, it would have to be my parents that helped me make that decision at that point. Do you know, like, if I had open growth plates and then I had a risk of growth plate arrest, like I've got one young boy who's got a very tall father, who was medical, and his father said if he got growth plate arrest from, and it was 10 or whatever it was, at this point in time, the disability would be huge. You know, because he's got a lot of growth left.
Got one leg that's going to be half the leg.
Exactly. So he said, I would rather do cross-bracing and see where it ended up. And even if it bought us a little bit more time until he was more skeletally mature, and then there was less growth plate arrest or less leg length or leg malalignment, as sometimes happens, risk, then we'd rather do that. So we have braced a number of people like that, who, with obviously full consent of their parents and them, knowing that they weren't predicted to get the best quality heel, but it would buy them some time, and it may be enough. Do you know? But we do know the grade 2 heels seem to have a higher re-rupture rate than the grade 1 heel, so that's something. But we don't know if it's any higher than ACLR, which is significantly for young pivoting females, very high. Do you know?
I mean, I know one right now who's on her third. In alpine elite skiers will do 5. In their careers. So
I know
there's some weeds, right?
Well, and that's the whole thing, I suppose, is
because you're solving the first one, right?
If we were doing a perfect job of this now, then we wouldn't be having to look at all this. But 50% of people are dissatisfied 2 years post ACL injury, no matter how they manage it, right? So I don't think we're doing a perfect job with these people.
Do you think it's possible, though?
I don't think it's possible. I think that people have unrealistic expectations about what it is that they're going to. They just say, oh, I want to get a reconstruction because I want my knee to be normal. And that's probably why isn't it normal 2 years past? We probably need to do a better job at educating people about, you have had a serious knee injury, you've dinged up some of your cartilage in your knee when you did this injury, this in 50% of people will lead on to some degenerative changes. And, and then the Frabel trial, the 10-year data has shown that actually in the non-operative group, it's slightly lower the OA risk compared to the other groups. So, and again, it all comes back to people's choices because, is it, you know, for some people, do or die, they just want to go back to soccer, football, netball, whatever. They don't care about the long-term health of their knee. But other people I see say, I just want my knee in 10 years' time to be good enough to do my job, go hiking, you know, do travelling, those sorts of things.
I want to live,
So it's really, and that's where AI can't really help you, in that you really need to have a very involved conversation with people about...
There's a difference between a pivot, someone going back to sport, someone going back to lifestyle and just existing. I mean, I've experienced this, and I'm sure every other physio has experienced this, where you have something 35, had a really classic 35-year-old who, you know what a slut drop is?
A what?
It's called a slut drop. Griff, can you do a slut drop right now? You're in the club, you're dancing. It looks like this. Ready? Go on.
Oh, wow.
It's a dance move.
It's different to the worm. I saw the worm viral thing. Did you see that?
Yeah.
He was a physio, actually.
Yeah. I did see the worm viral thing. She, the idea is that this patient had come to see me. She was 35, public servant, non-active, slut dropped in, obviously it's a bad term, whatever. But she did it at a place called Mooseheads. I'm sure you're familiar with Mooseheads.
I've been to Mooseheads.
She was in downstairs Mooseheads, slut dropped, did her ACL, right?
Wow.
Yeah, must have,
it's a
whatever.
Very unusual mechanism.
Yep, and then saw me, but she was on the piss, so who knows,
Yeah.
right? Yeah. And, you know, big knee. And, yeah, ended up getting a surgery, had a bad experience, DVT from the surgery, ended up in hospital with a PE.
Wow, yeah.
She doesn't do sport.
Yeah.
You know, I think that this is where something like this comes into it. I've got a couple of quick hits. We just do a couple random questions. I think for you, this might be a little bit interesting. Yeah. And again, they're just dumb questions. But let's start with this. What's your favourite movie?
Oh, well, I just saw Devil Wears Prada 2.
Oh, is it good? My sister
I loved
just
it.
saw. Did you like the first one?
I did like the first one. It's not my favourite movie of all time, but it's one that I've seen very recently that I enjoyed.
Is it original cast, Meryl Streep?
Yeah, it is, and that's incredible that they got all those people together, and you know, and a few little extra, like Lady Gaga comes on, and Stan Tucci's there, and you know, I love all those.
Nice,
yeah, it was great. It was fun.
If you could be pro at any sport, what would it be?
Oh, wow!
I like that you're smiling.
That's an interesting question. I don't know. I played a lot of sports when I was younger, and I enjoyed all of them. Yeah. But I probably I did a lot of athletics when I was younger.
You said long jump. That was, remember when you brought it in? That was the first thing you thought.
I don't know, but I had more fun playing team sports. So I really enjoyed netball.
Yep. Isn't that ironic?
Yeah,
ACL, complete reset.
Well, actually, netball. And I gave up playing netball.
Have you done your ACL?
No, because I was very proactive. I'm Captain Sensible, do you know, that? Obviously, my daughter, who's trying to become an aerial skier, she's not got that from me. But anyway, no, I sort of thought when I was about 38 or something, 40 or something, and I'm like, you know what, I've had a pretty good time of this. Do you know? So I reckon I'm going to retire while I'm ahead, because I know my risk is getting more every year now, so I'm going to pull out.
Sure. Pro netball sounds good though. Yeah. I think that,
although I don't know about the conditions for the pro netballers. I'm not very, happy about their conditions. But anyway.
That sounds like another good chat. If you could pick another allied health to do, what would you pick?
Well, probably if I always have really loved, all the ED sort of stuff. Do you know, I would probably be like a paramedic, sort of sort of retrieval paramedic, or in an ED sort of thing. That would really, I love all that.
Have you watched The Pit?
I love all that stuff. I love all that really acute medicine stuff, and because I was really early in my career, I was tossing up between ICU and sports physio, which are so different. But I loved all the medical stuff of ICU. But the physio scope I was less happy about. So.
Was there a point where you were tossing up doing medicine then? Back when you were maybe talking to these doctors and
if I was
surgeons?
me now, I would probably have done medicine. Yeah, because I think back then, medicine was a different career for women. Like I'm talking about a long time ago when I finished school, 1983. And I remember at the time thinking, oh, well, most women in medicine are either anaesthetists or GPs, and I don't want to do either of that. Do you know, like, so, and then I thought physio suited my, like I played a lot of sports, I enjoyed that, and I thought that sort of suits me better because then I can be more active in that realm. Absolutely. And I've done a lot of work in sports in my past. Tennis, athletics, netball, gymnastics, all sorts of things, which I've really enjoyed. Do you know? But so.
Last question. Think of away from, maybe not necessarily away from ACLs, but what's the most highlighted side hustle you've done? Like a little, like I know you worked with Naomi Osaka. And
the Williams sisters, actually.
One of those maybe the highlight? I mean, because obviously I feel like the ACL stuff you're doing is the pinnacle of your career, but surely there's a really fun side hustle you've done.
The ACL stuff is my academic pinnacle. You know, like I've had a lot of little mountainous enjoyments through many different, particularly when I was working in the UK, where I worked with lots of celebrities and in film studios.
Oh, wow. That's cool.
So I've worked with a lot of very interesting people. I probably can't say their name, but anyway, lots of big film stars I have worked with, in addition to the Williams sisters for many years and Naomi Osaka as well. So it's just, and I think the thing that I've learnt from those sorts of side hustles is it's always amazing to see people at the pinnacle of their career, no matter what that is. Do you know, like, and what probably drives them and how they do it. Do you know, like, and so I remember something that Serena said to me, and I thought, this is the mindset of somebody who is mentally really tough and also just a really elite, you know, like at the top of their game. And it was just one of these days in Melbourne where the court, like was at the Australian Open, the court was almost melting. Do you know, like it was like,
really
like
hot.
I couldn't believe the heat rule wasn't, it wasn't, and it was just, you know, and I remember her when she was interviewed at the end, she said, it was so hot out there, it was like I was having an out-of-body experience, is what she said. But I remember walking out there with her and I said, now it's really hot, you're going to have to make sure you hydrate a lot, you've got your ice vest, your ice towels, all of this stuff. And she said, yep, and it's hot for my opponent as well.
Huge.
See, and I was like, wow.
She's not even thinking about,
I'm like,
seeing the advantage part
wasn't
of it.
even thinking about it. So it was just like, and I just thought that's a good learning from somebody, just like, you know, when you're out there and you've just got a single track, you know, mindset about something.
How fun.
You know? Yeah.
How did the attitude, I guess, or personality when you look at it, like, because it's side hustle, I can't talk to you for ages, Jane, where you look at the celebrity side, who's an actor or someone who's at the top compared to a Serena Williams, do they have a shared trait or do they have a different mindset in that space? Because you're talking about the top of their career.
Because I suppose I understand the mindset of sports people more. And I suppose having worked with them, as I'm sure you have, it's like, you know, injuries to sports people can be very meaningful to them because it's their whole career, livelihood, self-esteem, everything. The celebrities were just fun. And funny.
How good.
Some of them, you know, but
I know you want to drop a name, but that's why. I know you're so almost so close to it. That was such a really cool chat. Really enjoyed it. Can you just remind us again the websites and the links and all the things that you were talking about?
So I suppose all my courses, like acute spotting knee, cross bracing protocol workshop, training workshop for physios, dry needling courses, which I've written as well, both the level 1 and the refresher course, and also the webcasts, specialist webcasts. They're all on Physio Educators.
Cool.
Which is my education platform.
Nice.
And then the Good Knee is the knee website that's coming at the end of the year, which is going to have links to all of it's going to have more general knee information, but to start with, it's going to have more ACL specific information, particularly with some free resources for patients with links to credible papers, but also the decision aid, and then some basic cross-bracing information. And then there's going to be a firewall which has some paid content as well. And then obviously a lot of these courses I teach through the APA as well.
Sure.
So so that's the main. And then of course the Embrace trial, if you've got anybody that's appropriate for the RCT. And the decision aid is www.aclinjurytreatment.com. And then if you want to read my Churchill website report, you just look up the Churchill Trust and fellow Jane Rooney.
Amazing. Well, thank you so much for joining.
Thanks. It's great.
Go enjoy the ruck. Absolute staple of Canberra.
Well,
I think it's a nice day for it. And we should catch up next time you're in Canberra, and we can go back to Civic Pub or Mooseheads.
Sounds good.